This is Dr. Daniels, and we are going to be doing endocrine disorders. So these are all the different disorders we're going to talk about. These are the glands in your body. You can see the pituitary, thyroid, adrenal, pancreas. And we're going to basically talk about, here's an overview of the endocrine system. So every cell in our body is under the influence of our endocrine system. So in order for our body to maintain homeostasis, that equilibrium at a cellular level, that's the endocrine system controls that. So it helps communicate and coordinate systems through chemical substances called hormones. And these hormones control a number of different physiological activities. So reproduction, how we respond to stress or injury, electrolyte imbalances, our energy, our metabolism, our growth, maturation, aging, all of those are influenced by these hormones that are communicated by the endocrine system. So if there's any upset to this system, illness or worst case scenario, death can result. Now, endocrine glands are the hypothalamus, the pituitary, thyroid, parathyroid, the adrenals, pancreas, ovaries, testes, and the pineal gland. And endocrine glands actually produce hormones which are secreted into the blood where they affect specific target tissues. So, and they don't have ducts. So they actually secrete. Other body organs secrete hormones, but like the kidneys, the heart, but these are exocrine glands because they secrete substance into ducts that then empty into body cavities. So endocrine glands, like what we're going to talk about today, they produce hormones which are secreted directly into the bloodstream. The other ones, like exocrine, yes, they secrete things, but again, they get secreted into ducts that then empty into the body cavity. All right, so in general, when we're talking about the endocrine system, we're going to talk about assessment, physical exam, those type of things. So we need to get a really good history. So past medical history, we need to know things, if they've had any kind of past endocrine disorder, and also things like, have there been any changes in their weight? How is their hair distribution and quality? What are their body proportions, like muscle mass to fat distribution? Have they had any changes in their level of consciousness or their mood, behavior, any changes in their menses or their libido, any intolerance to heat or cold? Have they had any skin, color, texture, temperature changes? Any changes in their thirst or urinary patterns? These might all indicate that there's an endocrine issue going on and will help direct us to which endocrine issue it is. Medications, we need to understand, if they're on any over-the-counter medications, if they take insulin, anything for their thyroid, steroids, corticosteroids, surgeries, and any treatments, like have they had chemo or radiation, especially anything above the neck, or surgery of the brain, or like a traumatic brain injury that might have affected. On physical exam, we need vital signs. We want to note particularly any cardiovascular changes, so heart rate and blood pressure. We want a good weight and height, their emotional or mental status. Diagnostics. We're going to get things like blood, urine, ultrasound, x-ray, CT, MRI. These are all going to tell us if there's tumors what the value of the hormone is, if it's too high or too low. And when we talk about treatment, basically, treatment usually requires management of that deviant hormone by either, because the hormone has either too much or too little production or secretion. And there are things that are modifiable, like medication, stress, diet, obesity. We can change those. But there are non-modifiable things like family history, or if they have an endocrine illness or trauma or aging. Those are harder to treat because they're non-modifiable. But with treatment, we're focused on that too little or too much and correcting the imbalance. Our assessment findings, we're going to look at things that are, the skin, particularly the color. Are there any location of lesions, bruises, rashes, symmetry of the body, the size of the body parts, any abnormal sounds or odors that the body's making. We're going to auscultate first, especially the heart and the lungs. We're going to palpate for texture, tenderness, temperature. Is it moist? Do we feel any masses? And percussion, again, for tenderness or any sounds, particularly like if the pancreas is enlarged or there's a pleural effusion or a tumor that might be secreting hormones. And then there's effects of aging. When you get older, hormones decrease in their production and their secretion. They might have altered hormone metabolism. They don't have the same response to target tissues. And there's alterations in that circadian rhythm. You can hear my puppy right now playing with her toy right next to us. All right. So the first one we're going to talk about is hypopituitarism. So this is a growth hormone deficiency. So the pituitary gland is in the brain. And let's look at this little chart. These little diagrams are thanks to Dr. Chastain. So next time you guys see them, you'll have to thank her because she did them for us. So the hypothalamus is like the master gland. It tells everybody like what to do. And it produces and releases hormones that stimulate the pituitary gland. So, and either it's going to stimulate the anterior pituitary or the posterior. So when we're talking about hypopituitarism, we're talking about the anterior pituitary. And again, that's located at the base of the brain. So with hypopituitary, we are going to have a decrease in that growth hormone, which the growth hormone is called somatotropin. And this is normally secondary to some kind of tumor in the pituitary or the hypothalamus. So usually it's normal at birth. The pattern progressively decreases. It's idiopathic. We don't know why they get a tumor in the hypothalamus or the pituitary, but that tumor causes a decrease in secretion of the growth hormone. Well, growth hormone normally stimulates cell growth, but when it's decreased, it won't. And it normally increases protein production. So when you don't have growth hormone, it won't. And it normally aids in fat mobilization. So again, you don't have growth hormone, this doesn't happen. And it normally helps with carbohydrate use. But again, no growth hormone, we're not going to be using our carbohydrates. Assessment, again, we're going to be looking at family history. We want to know the parent height. If the parents aren't, if the parents are 5'10", or small, 5'6", then the kids aren't going to be hugely tall either. So is this normal? Is the parent height correlates with the child, the birth size and growth? Physical exam, we want to know about any drugs or nutrition. Is there like a nutrition reason why the child's not growing? And we're going to do a good review of the systems, which we talked about already. Diagnostically, we're going to obviously look at growth hormone levels, and they will show a deficiency. Typically, this is done by a radioimmunoassay of the plasma. We can do an MRI, which helps rule out any lesions in the brain. We can do an X-ray of the hand or wrist, and that shows us, ossification of the bone to see bone growth. So if we normally, growth hormone stimulates cell growth, and we're not stimulating cell growth, we're going to have short stature. This is the chief complaint. Child's just short. And they're normally keep up with their peers the first year of life, and then they fall off the growth chart to less than 3%. Their sexual development is also delayed. They don't produce protein, so they have decreased lean body mass, meaning they're just well nourished. So their height is lower, but their weight does not go lower. So they can get on the junky side, right? Because they have decreased lean body mass. And then they're not using carbohydrates, so they have decreased energy. They're inactive. They feel tired all the time. In addition, their permanent teeth can be delayed. So their primary teeth, like their baby teeth, will appear at the expected age, but the permanent teeth come in, later. And then they end up with overcrowded or crooked teeth. So how do we treat it? If there's a tumor, we remove it. All right? It's a tumor. Take it out. And then we might have to treat with medication. So we might have to give them growth hormone. So we take the tumor out so it doesn't continue to decrease it. Plus, we need to give them something. And since growth hormone is somatotropin, it makes sense that that's what we give them. So this medicine is given sub-Q every hour of sleep. And that's because we want to mimic normal. So growth hormone normally gets made at night. So that's why we give this at night to kind of mimic what's normal. But it is super expensive. It can cost about $20,000 to $30,000 a year. So parents really need to be educated, because if they use the growth hormone right, then they're going to have successful results. About 80 to 90% of children will attain eventual adult height if they're, diagnosed and treated early. Now, it's just going to be slower, but they will attain that same height. We want to increase lean body mass, so we got to make sure that they're exercising, they're eating well, they're doing those things, because just because their height is shortened doesn't mean that their weight is going to be, stunted also. And then we need to increase their energy levels, get them to, exercise but not too strenuously, and group activities and do things for them. That's going to help, because they're going to feel more tired until we start giving them more growth hormone. Obviously, lots of emotional support and realistic expectations. Letting the parents know that they're going to obtain adult height, but they're not going to be like a 6'5" NBA star. In that it's going to take a while for them to get to that normal adult height. So their little boy might be, the shortest one in middle school and high school, which can be hard, because other kids are picking on them and, all those developmental things that we talked about. All right. So opposite of that is hyperpituitaryism. So again, we're looking at that chart. And now the hypothalamus tells the anterior pituitary to release growth hormone. And again, probably because of some kind of tumor, it releases too much growth hormone. So it's either going to release too little or too much. So with hyperpituitarism, it's releasing too much. And it depends on when they're getting the growth hormone to determine what kind of clinical manifestations you're going to see. So with giantism, this is when they get growth hormone, too much growth hormone before the closure of the epithelials, oh my goodness, I can't say it. Epithelial plates. So remember we talked about the growth plates and how they stay open up until they're about 18 to 20 years of age so that the child can continue to grow. So if they get a lot of growth hormone before those plates close, then they're going to have overgrowth of their long bones. And this is the person who's greater than 8 feet tall. So the picture that you saw on the last slide of the tall man, it reminds me, I just saw The Greatest Showman. And these are all the people that had these endocrine, basically circus people or people who had endocrine disorders that we just didn't diagnose back in the day. Such a good show, by the way, if you haven't seen it. If it is acromegaly, then they have their growth hormone is increased after those growth plates have already closed. So they grow at a normal rate and they're like normal adult height, but now those close and some kind of tumor or whatever increases the production of growth hormone. So then you get things, oh, that went crazy. Then you get things like soft tissue swelling. So the head, the lips, the ears, the nose, the tongue, the feet, even organs like the heart or the kidneys, the vocal cords, those all lead to those soft tissue swelling. So if the growth hormone stimulates cell growth, it's going to stimulate it even more because it has more growth hormone. And so we're going to have, again, the overgrowth of bones and soft tissue, especially the hands, the feet, the face. It's going to increase production of protein. It's going to increase fat mobilization. So they're going to be on the skinnier side, right? So they have increased fatty acids and they have increased carbohydrate use. So they tend to use up or have high glucose levels, which we're going to talk about. So with the overgrowth of the bones and soft tissue, they get joint pain. They get soft tissue swelling, including swelling of the organs, which can lead to organ failure, especially of the kidney and the heart. So we're going to check for things like urine output and cardiac output. How's their heart rate? How's their blood pressure? Because that's going to tell us that there's a problem. They'll get enlargement of the tongue and also some malocclusion of the teeth, so they can have speech difficulties. So we might need to refer them to speech therapy. We might need to monitor their airway more closely. They get hypertrophy of the vocal cords, so they tend to have a deep voice. Increase pharyngeal tissue, so they have narrow upper airway and often have sleep apnea. So they may need to sleep upright at home. They may need a sleep apnea machine at home. We need to assess their quality of sleep because if they're not sleeping well because of the sleep apnea, then they're not going to function well during the day. And their skin is very thick and leathery and oily with deep creases. They're at risk for atherosclerosis because of an increase of fat mobilization, so they have increased fatty acids. And again, we said that their increased carbohydrate use, they have high glucose levels, so they're hyperglycemic. So it increases their risk of diabetes, and both of those, that risk for atherosclerosis and the risk of diabetes, decreases their life expectancy. And typically, it decreases it by a good 5 to 10 years. So diagnostics obviously, we're going to get, again, the immunoassay, and we're going to see increased levels of growth hormone, which, again, is the somatotropin. Obviously, clinical manifestations are going to help with the diagnosis. X-ray, CT, or MRI will show us if there's any tumor. And endocrine studies to see if there are any other hormone deficiencies. Because a lot of times it's just not this hormone that's messed up. There's other hormones. Because especially if it's in a tumor in the hypothalamus, and the hypothalamus controls all the endocrine system, then you can probably assume that other hormones are going to be affected. So treatment often includes hormone therapy for anything, for any necessary, losses. So treatment, we're going to treat with somatostatin. That is different than somatotropin, okay? Somatotropin is growth hormone. We don't want to give them more growth hormone because they already have too much. So somatostatin inhibits, the growth hormone until we can get surgery or radiation, so that we don't, continue to have symptoms. Treatment is going to include radiating or removing the tumor altogether. And then because we radiate the tumor, we're probably going to be messing with the hypothalamus or pituitary. So we're going to have to supplement with all hormones after surgery. So that's the hard thing for, I think, both healthcare providers and especially for parents and children and families and patients, whatever, to understand, is that they say, oh, well, I had hyperpituitarism. I had too much growth hormone, and I had surgery to fix it. And wait, now you're giving me growth hormone? Isn't that what you treated me for? Well, the problem is once we take away that tumor, we're also taking away all of your ability to make that hormone. So anytime we have something with hyper, we end up having to replace it once we radiate or remove the tumor, because we radiate or remove the hypothalamus. Again, emotional support is always important. And we've kind of talked about this, patient advocate, what's your focus for clients? All right, so which of these observation leads the nurse to suspect a diagnosis of acromegaly? A, cyanosis, B, exophthalmos, C, hyperpigmentation, or D, deep voice, enlarged forehead, and tongue. And it's going to be D. Remember, with the acromegaly, it's the swelling of any soft tissue. So your vocal cords get swollen, causing the deep voice. They get the enlarged head. They get the enlarged tongue. All right. So we talked about the pituitary. Now we're moving on to the thyroid. So pituitary was in the brain. Thyroid's in the neck area. So with hyperthyroidism, you have hyperactivity of the thyroid gland, okay? So this is what normally happens in the body. The hypothalamus stimulates TRF, which tells the pituitary to stimulate TSH. The TSH, which is the thyroid stimulating hormone, tells the thyroid to make T3 and T4. These normal levels, so then the hypothalamus reads the levels of T3 and T4 to then determine what to do. It's part of the chain. So normally, if there's low T3, T4, the hypothalamus reads the low T3, T4 and says, hey, TRF, kick it up a notch. And then tells the pituitary to kick it up a notch, which tells TSH to kick it up a notch, to tell the thyroid to make more T3 and T4. Now, if the T3, T4 get too high, then the hypothalamus reads high levels of T3, T4. So it tells TRF, it says, hey, calm down, we've got plenty, or we've got too much. So the TRF tells pituitary, slow it down. Pituitary tells TSH to slow it down. And that tells the thyroid, hey, calm down in making T3 and T4 because we have too much. So that's the normal, pattern it follows. Well, what's happened with hyperthyroidism is that the thyroid becomes enlarged, and it can become enlarged from a variety of things. It can be, the most common is Graves' disease, and that's autoimmune. It can be because of a toxic nodular goiter, which is an enlargement of the thyroid gland. And that's mostly caused due to a lack of iodine. It can be because of too much iodine. So the goiter is a lack of iodine, or it can be too much. There can be a pituitary tumor, so it's nothing to do with the thyroid per se, but the pituitary is messed up and causing the thyroid to be messed up. It could be cancer, or it can be a thyroiditis, which we're going to talk about next. That leads to that's going to lead to Hashimoto's, which is hypothyroidism. So, but Graves is definitely the most common form. It's about 75% of cases, and it can have remissions and exacerbations. It happens in women more than men. 20 to 40 years of age is the highest frequency, and children peak incidence is around 12 to 14 years of age. So because the thyroid's enlarged, it says, okay, T3 and T4, kick it up. Let's start making it starts making high levels of T3 and T4. Now, normally, the hypothalamus is going to be constantly reading these high levels of T3 and T4. So it's going to tell the TRF to slow down, right? Because it's saying, hey, I've got a lot of T3, I've got a lot of T4. We don't need to make any more right now. So go ahead and calm down. So the TRF tells the pituitary to tell thyroid stimulating hormone, hey, slow it down. We don't need a whole lot right now. So your TRF is low, your TSH is low because the hypothalamus is constantly reading high levels of T3 and T4. But once it hits the thyroid's like, whatever, I'm enlarged. I'm going to just keep on kicking it. So I'm just going to keep on making high levels of T3 and T4. So the thyroid, instead of continuing this loop, just kind of takes over. So your TSH is going to continue to be low, and your T3 and T4 are going to be high for this reason. So clinical manifestations. So if T3 regulates the metabolic rate and we have increased T3, then with hyperthyroidism, we're going to have increased metabolic rate. So these patients have weight loss and muscle wasting, increased appetite. They're hungry all the time, despite, being super skinny. They have diarrhea because of the increased peristalsis. Their abdomen's their metabolic rate is just moving right along. They have a bounding high heart rate, palpitations, high blood pressure, tremors. They're heat intolerant. They often have warm, moist skin, like with facial flushing. Amenorrhea, so they don't get their periods. They get exophthalmos, which is the protrusion of the eyeballs from the orbit, and that's because of impaired venous drainage from the orbits, so the eyes bulge out. They're nervous, restless, they can't concentrate. T4, on the other hand, it controls cell growth. So, again, we're hyperthyroidism, so we have increased cell growth. So, increased body cell growth. So, they get hair loss, and their hair that they do have is very fine and silky. They can have a goiter on their thyroid, and you can hear a bruit because of that increased blood supply trying to go through. So diagnostics, obviously labs, we're looking at low TSH and increased T4, free T4. T3, T4, like serum T3, T4 are not as useful, but free T4 and increased and low TSH is what's going to help diagnose hyperthyroidism. We'll also look at thyroid antibodies. We'll look at an ECG. We're worried about AFib, with palpitations because of all the increased blood supply. We'll do the eye exam because of the bulging eyes. We'll do a thyroid scan, needle biopsy, obviously clinical manifestations like telling, because they're not going to come in and say, I always say this, hi, I'm having hyperthyroidism right now, so could you please get my levels and check them? No, they're going to come in complaining of, I'm hot all the time and I eat a ton and yet I can't seem to gain any weight and I always feel like my heart's beating really fast. And those are going to be clues that we need to further investigate. We can do a radioactive iodine uptake. That's the RAIU. And that's where we give a little bit of iodine to see the thyroid light up, because there'll be increased uptake from the thyroid. So treatments for thyroidectomy and nursing management. The treatment of choice is the radioactive iodine. It helps kill the thyroid. So the thyroid's enlarged, and we give it a ton of radioactive iodine, and the iodine kills it off. It can take 6 to 8 weeks. And then again, remember, they become hypothyroidism afterwards because we take the thyroid out. So we break up that chain. So we had too much, and once we kill it off, now we're not going to have enough. So then we're going to be treating them for hypothyroidism afterwards. We can... The second one, which is not curative, is to give antithyroid drugs, and those are PTU and Tapazole. PTU has some side effects, though, like sore throat and fever, so you do want to make your patient aware of that. And basically, they inhibit synthesis of thyroid hormones. So maybe why we're giving the iodine and the 6 to 8 weeks it takes to kill it off, or before we do surgery, they might get these antithyroid drugs just to kind of help inhibit more synthesis of that T3 and T4. And then if the radioactive iodine doesn't work, then we would do a thyroidectomy. And that's where we remove the thyroid. And again, once we remove it, we are going to be then treating them for hypothyroidism. ABCs are really important. This is on the neck. We're doing surgery on the neck, so we have to worry about airway. There needs to be a trach at the bedside, and suctioning at the bedside, oxygen at the bedside at all times, and the head of the bed has to be elevated. We're going to teach them signs and symptoms of hypothyroidism, because now that they're at risk for it, and we're going to be treating them for it. It says calcium decrease, but it's supposed to be calories. Let me fix that. I don't know if I can. Oops. Let me change it to blue. I'm just going to put cal decrease. Because before, remember, they were eating anything they wanted. They could have 12 Snickers bars and lose 10 pounds. Wouldn't that be amazing? But they can't continue to eat like that, because if they continue to eat like that, they're going to gain weight. They can't smoke. They may have some activity limitations. We need to look for signs and symptoms of thyroid storm, which I'll talk about in a second. They need to check for hypocalcemia, because the parathyroid is on the thyroid, and the parathyroid controls calcium. So when we take out the thyroid, we often take out the parathyroid, and we cause them to have low calcium levels. They keep calcium gluconate on hand for emergencies all the time, because they're at risk. Tell them to look for things like any muscle twitching, cramping, tingling or numbness, anything that shows that they might be hypocalcemic. They have to be more careful with. And then obviously normal post-op care like infection, skin and mouth care, those type of things they'll look for after surgery. Obviously, until we treat them, we want them to have a high calorie, high protein, high carb diet to counteract that weight loss, muscle wasting, that increased appetite. Once they're treated, though, that goes back down to normal. But until then, 6 meals a day. We don't want them to have high fiber foods because those are going to irritate. So again, this is nursing care management while we're treating. Once they're treated and we're just managing, then that's not an issue. But until treatment, we want to avoid high fiber foods so that we don't make the diarrhea worse. If they're having any heart issues, we give propranolol, a beta blocker. Now, if they have asthma or heart disease, they need a different beta blocker like atenolol. But some kind of beta blocker is going to help with their blood pressure, their heart rate. We're going to limit caffeine. Obviously, we don't want them drinking energy drinks or anything like that. That's going to make their metabolism even higher. They may need artificial tears because depending on how serious the bulging is, they may not be able to blink very well and get moisture on the eyes. And then the thyroid storm, that's what we're talking about. We need to tell them to look for signs and symptoms. Sometimes an antibody develops and attaches to that thyroid and causes this life-threatening condition. It's acute, so it happens fast. It doesn't happen very often. It's rare, but when it happens fast and it's life-threatening. Basically, all their clinical manifestations are heightened. And it's because of some kind of stress. So infection, trauma, surgery, anything that a patient who already has pre-existing hyperthyroidism, they get in a stressful event and they get this thyroid storm. And it causes severe increase in their heart rate, which can lead to heart failure. They can develop shock because of the diarrhea, because it's going to be significant diarrhea. They get hyperthermic, so temperature way up. They get hypertensive. They restless. They can even, go into a coma or have seizure activity. So it's just a very heightened response. So obviously, if it's caused by stressors, we have to stop the stressors. We want to keep them in a calm, quiet, cool environment. We're going to push fluids, drug therapy, oxygenation. We're going to monitor and treat for any dysrhythmia. So they need to be on an EKG. We need to keep a close eye on them. We're going to decrease that fever, just kind of balance, counteract all of the clinical manifestations. All right, so opposite of hyperthyroidism then is hypothyroidism. And this is where we're going to talk about Hashimoto's, which I mentioned in just a second. So when we're talking about Hashimoto's, that's basically when it's a thyroiditis and there's inflammation of the thyroid gland secondary to some kind of virus or bacteria. And if it's chronic, then it leads to Hashimoto's because initially they get hyperthyroidism, but it uses it all up and then they become hypothyroid. So that's where that comes in. So let's look at it. So there's different reasons. So normally I always do my etiologies in pink, I try to stick to my same colors so that you guys always understand. But because there can be different etiologies, that's where you're going to see different colors come into play right here. So again, normal is the hypothalamus, triggers, and sends TRF to the pituitary to stimulate TSH, to stimulate the thyroid to make T3 and T4. And depending if there's too much or too little, the hypothalamus is then going to trickle down and regulate that in that fashion. So when you don't have enough iodine, that's the primary cause. So there's destruction of the thyroid tissue because of some kind of iodine deficiency. Then you have decreased circulating thyroid. That's a primary cause. So you get decreased T3 and T4 because the thyroid is destroyed. There's not enough tissue there. And that tells the hypothalamus that says, oh, wait a minute, there's not enough T3 and T4, so we're going to send out more TRF to the pituitary to tell, TSH, to tell the thyroid to kick it up a notch. But even though it's saying, kick it up a notch, there's not enough thyroid tissue there to do it, so the T3 and T4 remain low. The other reason, a secondary reason, which I'm going to put here in gray, is because of pituitary disease. So something's wrong with the pituitary. So if the pituitary is not working, then it's not going to allow TSH. It's not going to signal TSH. So TSH is going to drop. The thyroid is okay, but because TSH is low, TSH tells the thyroid, calm down. So your T3 and T4 are low because of that. And then your low levels, it tells your hypothalamus to kick into gear. So your TRF is high, but because it hits the pituitary and the TRF is saying, hey, pituitary, kick it up because your T3 and T4 are low. But the pituitary is like, sorry, I'm broken. I've got some kind of disease and I can't work. So your TSH remains low and then your T3, T4 remain low. And then the third reason, which is going to be here in orange, is that Hashimoto's that I talked about, that autoimmune disease that destroys the thyroid. And again, it's just that chronic exposure to some kind of infection or whatever. And again, in general, hypothyroidism affects women more than men. Oh, and with Hashimoto's, the T3, T4 is low because, again, the thyroid's not working. It signals the hypothalamus and says, hey, TRF, get to kicking. And the pituitary says, okay, TSH, get to kicking. But because the thyroid is destroyed, it doesn't work. So clinical manifestations, we're going to look at them in general and also for if they have it at birth, congenital hypothyroidism. So again, T3 regulates metabolic rate. So for hyperthyroidism, the metabolic rate went up. But for hypo, which is what we're talking about now, the metabolic rate goes down. So we're going to have everything slows down. So instead of diarrhea because of increased peristalsis, we're going to have constipation. Instead of, being all roused up, they're going to be mentally sluggish. They don't remember things very well. They're going to gain weight. They're going to feel tired and lethargic, depressed. They're going to have decreased red blood cell production, which is going to lead to anemia. Instead of being heat intolerant, they're cold intolerant. They're always cold, hypothermic. They have personality changes. They get menstrual disorders, so they get really heavy. So instead of amenorrhea, they get really heavy periods, which can also contribute to the anemia. Their cardiac output is low. They have increased cholesterol and triglycerides. They also can develop a goiter. And again, T4 controls the rate of cell growth. So they're going to have decreased body cell growth. So they get that, they get myxedema, which is the doughy skin. They look like a little Pillsbury doughboy. They get coarse, sparse skin that's very dull, dull and puffy skin. They get periorbital edema. This is a very common clinical manifestation. It's called a mask-like face. Coarse, that we talked about the dry, coarse hair and skin. The thick, swollen lips and tongue. If it is congenital, meaning they have it at birth, infants, you'll note severe developmental delay. They'll be very sleepy. They have delayed growth, and they have constipation. So everything is slowed down in hypothyroidism. So diagnostics, obviously we're going to get labs, and remember, so if you see here, TSH is not as helpful. So because sometimes it's high, but if it's a pituitary cause, then it's going to be low. So TSH is not going to be very helpful for us for hypothyroidism. So the only thing that's really going to mark it is the free T4. So we're going to look for a low free T4. Again, ECG, because we want to notice any bradycardia. IMS is the infant metabolic screen. So if we are worried about hypothyroidism at birth, we're going to see it on the infant metabolic screen. And that condition is called cretinism. We'll look for thyroid antibodies. That radioactive iodine uptake test. So it will have decreased uptake of iodine. So think of everything's lower. And then you might also things like we talked about, like you might see anemia on the labs or triglycerides high. All right. So if so treatment-wise, if we're looking at the thyroid, basically we don't have enough T4, we have to replace the T4 because that's what we're concerned about, right? So this should kind of go more like down here. So we need to replace T4, and that's levothyroxine. Timing is really important. They have to wait to eat 1 hour before or after a meal in order to give it, because if you give it with eating, it's not going to work as well. So typically they get it at like 5 o'clock in the morning or 6 o'clock in the morning, and then they have to wait to have anything to eat or drink. You need to monitor side effects, which are going to be things, basically, if we're giving them T4, if we give them too much, they're going to have hyperthyroidism, right? It's all this homeostasis, this balance. So think about it. Anytime we do something to correct a deficiency or an excess, we worry that we're going to swing them in the opposite direction. So if I'm giving T4, my side effects are going to be too much T4, which are the side effects of hyperthyroidism. So I worry about weight loss, nervousness, tremors, insomnia, those type of things. If it's an iodine deficiency, we can give iodine. They may need a stool softener for constipation. We want to encourage mental stimulation because they're just going to feel kind of foggy and out of it. So anything that we can encourage mental stimulation. We have to be very careful with sedation with these patients. We can easily over-sedate them. Weight gain, they have to be on very strict calorie, restriction so that they don't gain weight because their metabolism is just slower. And again, these are mostly when they have active disease. Once we start treatment, like when we replace T4, then they may not have to monitor their calories as closely. We always want to monitor calories. But these things are mostly like during active disease. They need high fiber, high protein diet. We want them to encourage to express their feelings because, they are going to have these feelings of sadness and depressed. They need to be in a warm environment because they're cold all the time. We do activity as tolerated, and we still want them to be active, but we just, because they're going to be sleeping for these long periods of time. So they need that because their metabolic rate is slow, but we still need them to be active. That's going to help increase their metabolic rate. So this is kind of looking at the differences between hypo on the left and hyper on the right. And I know sometimes they, compare from Winnie the Pooh, if you guys are familiar with Winnie the Pooh, Tigger, that annoying bouncing tiger that jumps everywhere and goes crazy. That's like a hyperthyroidism, and Eeyore is kind of like your hypothyroidism. Like ho-hum, glum and slow and overweight. It's a good way to kind of think about the two. All right, so did we skip over? No. Infant with congenital hypothyroidism shows which clinical manifestations, and it's going to be C, delayed growth. Which statement by the client is most suggestive of hyperthyroid? I have chronic constipation. Well, no, that's for slow. All I want to do is sleep. No, that's slow down. The more I eat, the more weight I lose. Yeah, that sounds right. D, I don't have much of an appetite these days. Nope, that's slow. So it would be C. It is important for the nurse to include which of the following interventions in the plan for a client with Graves. So remember, Graves' disease is hyperthyroidism. So avoid tinted glasses. B, use artificial tears. C, lower the head of the bed. D, to relieve eye irritation, apply hot, dry compresses. It's going to be the artificial tears, right? Because they get the bulging eyes. Symptoms of hypothyroidism, which is Hashimoto's, are often masked by which of these biological processes? A, aging. B, puberty. C, inflammation. D, menstrual cycle. And it's aging. And then I seem to have left it out. I'm going to go back for a second. Somehow it got lost off here. But there is a complication part of this with hypothyroidism called myxedema coma. And let's see if I can grab my pen real quick. Sorry about that. I don't know how it got dropped off. But with so it's there you go. Myxedema coma. And again, it's triggered by infection or trauma or cold, maybe some kind of over-the-counter drugs. So again, anything that causes stress. And again, just like before, the signs and symptoms are like the clinical manifestations are heightened. So they get severe hypotension, they get hypoventilation, which is really scary, and they're very hypothermic. So the way we treat it is with IV thyroid, so IV T4. So okay, so I think that is it that I forgot. All right. I am going to go ahead and, since we're at about an hour, pause it here and start a second recording for the rest of it, okay?